now on until the effect of the muscle relaxant wears off. The anesthesiologist actually breathes for the patient and continues to control his respiration for the duration of the operation.
This was an incredible simulator. Did you notice the realism of the face and the way the eyes worked? They dilate and constrict. It detected the medications. It showed the position of the airway. It had all sorts of incredible advanced features. It was completely computer controlled. The simulator was called Sim1. It was developed between 1965 and 1968 by this gentleman, Stephen Abramson, and he was a medical educator, and an anesthesiologist by the name of Sam Denson, and an engineer by the name of Tullio Ronzoni from the aerospace industry. Not only did they invent, develop, produce, and use this simulator, they studied it and they wrote about it. Here's references for 4 papers they published showing the educational value of using the simulator. They compared the training curve of new anesthetists in their early learning with the simulator and without the simulator, and showed that those who used the simulator, their training curve was advanced and they made fewer errors in their initial practice. These were real champions. They had passion and they were willing to push their idea forward. I discovered that Sim1 appeared in the lay literature. Some of the magazines that I see on the shelves, Life magazine, Time magazine, National Geographic, all had articles about Sim1 during the late 60s. In fact, in 1972, Sim1 actually opened for a movie called Future Shock. And the video that you just watched was part of that movie. So these people were true champions. They were willing to push the idea forward. So I've crossed off those first 2 reasons. I don't think they were really missing ingredients. The ideas were there. There was certainly technology that made mannequins that in some ways are more advanced than the ones that we have here today. And there wasn't an absence of evidence. There were papers being written about the efficacy of using simulation for education. So maybe the medical model was such that it worked well enough that we didn't need simulation. Back to history a bit. The man credited with the kind of model that we use for training, the idea of a house staff with residents or registrars, whatever you want to call them, is attributed to the physician William Osler, who was at Johns Hopkins University in the early 1900s. And he came up with this concept of a house staff in about 1900. He's a very quotable man. There are all sorts of interesting quotes from Osler. One of his quotes was that he wished that his tombstone read, he brought medical students into the wards for bedside teaching. And so he's often given the credit for moving from the lecture hall into the clinical environment. So here's our registrar, really thrilled about it. This model has served us well. My favorite quote of Osler is this one. At graduation in 1918, he said the following, and I love this because I think it's still true. Gentlemen, they were all men, gentlemen, I have a confession to make. Half of what we've taught you is error. And furthermore, we don't know which half it is. So in Osler's time, the quantity of medical knowledge that an individual had to retain in order to practice was manageable. And even though half of it was wrong, it wasn't all that much. But we know that the rate of medical knowledge has increased over these decades, and there have been various estimates made of how fast it increases. And so I found a number of references for the rate of doubling of medical knowledge, somewhere between 1.8 and 18 years, medical knowledge doubles. And so the problem started to become there was just too much to know, too much to learn in order to practice. And so in the 1940s, we saw the advent of specialties, and specialties came about just for that reason. There was just too much to learn, too much to know to be able to practice successfully. That's accelerated over the decades, and so we've gradually lengthened and stretched the learning process in all specialty areas so that our specialty training has become longer and longer. In the past 20 years, we hear cries for we need a new medical education reform. We need another Flexner report. We need another Osler to redesign medical education. So I submit that this problem was in existence all through the quiescent period, and at any moment we could have said simulation could help us redesign the medical model. The last issue was that there was no supporting financial structure, and this is an argument that I don't have much to refute. There's very little evidence of money being spent to develop new educational models, especially simulation. There were a few grants given here and there. Sim1 was developed under a grant, but there was no money to support its use, and so it disappeared from the scene. Patient safety. So the other argument that's been made is that there was no patient safety problem that the world was aware of that needed addressing. So I actually have my for my birth, I thank the patient safety movement. I was delivered by an obstetrician. And actually, I have my mother's surviving my birth to thank to the patient safety movement, because being delivered by an obstetrician back in 1850 was quite dangerous. And this man, my hero, Ignaz Semmelweis, made a really interesting discovery. He noted that the death rate among women delivering babies in the hands of obstetricians dying from septicemia of childbirth was staggeringly high and was much higher than the death rate from septicemia of childbirth in the hands of midwives or lay birth attendants or even being delivered on the street. And so that insight and study that he did led to a really interesting patient safety solution, one that we're still struggling with here in 2011. And so he said, wash your hands. And of course, he, after much ridicule, got his trainees at least to wash their hands, and the death rate plummeted. And so patient safety has been around for centuries. In my healthcare career, I know that almost every day there's been a conversation about patient safety. We've always been concerned about patient safety in healthcare. We've tried everything in our power to try to reduce the rate of medical accidents and errors. I guess it just wasn't available. That concern was not available to the public at large. And so a patient safety problem was not one that I think was appreciated. And so I've already mentioned the financial structure wasn't there. So what happened in 2090 to change all this? None of these ingredients seem in and of themselves to be completely missing, yet something about them rings true, and something occurred in 1990 to change this. So the video work. So this is a video of a simulation in 2010. Notice in the corner they're splitting the chest. They're opening the chest to expose a beating heart. This is a full team immersive simulation. It has physiologic, environmental, and task simulation combined. Note that it has coordinated physiologic monitoring for the anesthesiologist, for the perfusionist, and for the surgeons. What was it that made simulation, full immersive simulation like this with a high degree of realism, much more common in our current world? So maybe the ingredients weren't missing. Maybe we just needed some better ingredients. Simulation, I guess, had to be rediscovered, and there had to be new champions. And so, at least for mannequin simulation, these two individuals get a lot of the credit. Back in 1989, David Gaba on the west coast of the United States and J.S. Nick Gravenstein and his group on the east coast of the United States rediscovered the idea of mannequin simulation and began to experiment with it and promote it. I spoke with both individuals. Nick Gravenstein is now deceased, but before he died, I had a conversation with him at one point, and I asked them, what about Sim 1? I saw that incredible video of Sim 1. Did you take your idea from that? And neither one of them had any idea of the existence of Sim 1, even though it appeared in various magazines. There were other champions, and so I think the various societies that developed in the mid-1990s, early 1990s, are a metaphor for a community of champions, people who latched on to this idea of simulation and decided to collectively advance the idea forward. So the Society for Simulation in Healthcare, the Australian Society, the Japan Society, the Dutch Society, the European Society, various other organizations came together to try to create a community of champions who would advance the field. Technology certainly made a contribution. It is nearly impossible to appreciate the changes we've had in our lives in the past 20 years. The advent of the transistor in the 1950s led to microcomputers in the 1970s. Advances in software integration of these technologies have changed our lives in really dramatic ways. And of course, they've made a contribution to development of simulators. So they've influenced, at least in producing simulators cost-effective in the new era. I would also add that new materials, or at least applying new materials to healthcare simulation, also helped advance the development of simulation as a field. In my opinion, this has lagged behind some of the other developments, that the development of the technologies of the simulators from the level of Sim 1 hasn't gotten us yet far enough, and there's lots of room to move forward. However, I've noticed in the last couple of years, as I've traveled around in the exhibit areas, some real innovations, real new ideas that I think are the beginning of a surge forward in this area. Another ingredient is the changing of the medical education model, and this has been quite noticeable. It's widely understood that the unit of medical education, of healthcare education, is changing. It's changing from the individual, the lone practitioner, to the team. And so healthcare is becoming a team sport, and consequently the need to train people, to educate people as a team has come forward. In addition, among healthcare educators, it's generally recognized that didactic education, speaking to people from a podium, as I'm doing now,